Right. Well, welcome. Good Wednesday evening, and welcome and thank you for joining us for Community Partners Presents program. Looks like we've got a good number of people who have already gotten their computers connected, so we'll go ahead and get started. I'm Kathleen Christ, and I'm the Executive Director of Houston Area Parkinson Society. This is our Community Partners Presents program, which began in 2020 because you guys asked for more ways to learn about the growing list of treatment options and latest information on Parkinson's. Um, Tonight, we're going to be talking about deep brain stimulation, which has been on the list of treatment options for a while. But over time, we've learned a lot more about this option, how and when to better use it. And there's a lot of technology updates that we need to kind of keep up with. So you'll be hearing some of that this evening. This is a sponsored content session. So this is with the goal of offering you additional information that you can use to aid in discussions with your physicians about disease management and your long-term treatment strategies and approach. So we really want you to be empowered to be informed consumers when it comes to your care. And so this is not only just about a treatment option, but then a device choice on top of that. And so there's a lot to learn and understand. But we're going to get started with the stuff that you actually registered to hear about. And so I will, if you've done this before, then you know how it works. I'm going to, we'll introduce our speaker. Our speaker is going to present. And during that time, you're welcome to put questions through in the Q&A feature on your Zoom account. Most of the time it's down at the bottom. And, or if you have my number and would like to text me questions, I'll also be monitoring that. When Dr. Faraji is finished with his presentation, then we will get to your questions and hopefully we can get all of those answered before we wrap up this evening. So with that, I just want to say that I'm happy to welcome our community partner, Medtronic, and our featured presenter, who's a HAPS Medical Advisory Board member, Dr. Amir Faraji. We are lucky that we have such great community partners, and Medtronic is probably our longest standing industry supporter, and we are all thrilled to be working with them. So I am going to turn this over either to one of our friends, Todd or Judd, who's going to take it from here, introduce Dr. Faraji. Dr. Faraji will get started, and then we will come back. I will see you back on the flip side with questions.
Yeah,
Todd,
I'll
Judd?
take it. Thank
Okay,
you so much, Kathleen. Can you hear me okay?
we can.
All right. Well, thank you, everybody, for allowing us to be on this evening. And I love that I have the pleasure of introducing the esteemed Amir Faraji, Dr. Amir Faraji. He is the functional stereotactic neurosurgeon here at Houston Methodist. Dr. Faraji probably does as many of these procedures than anybody in the country. So we're very happy to have him as a local partner here in the community of Houston, Texas. And at this point, I'm going to pass it off to him.
Thanks, Todd. I appreciate it very much. Let me just share my talk for everybody. And I want to thank you all for joining in tonight. So, again, I have this esteemed pleasure of talking to you about DBS. It's a technology that I really believe in, and it's close to my heart. I think it really gives patients their lives back. And I really wanted to showcase the new modern approaches that are done with deep brain stimulation in terms of Parkinson's treatment in particular. And a lot of that is related to work developed through Medtronic. So again, I talk every time I give a talk, especially to a patient crowd, I always show this because it's important to pick your surgeon carefully, right? Surgeons are not the same. Neurosurgeons are not the same. There are a lot of surgeons that specialize in tumors, spine, peripheral nerve, but there's a special type called functional neurosurgeons that really specialize in the treatment of Parkinson's disease. And that requires subspecialty training or fellowship training afterwards. And that's what I did. Through my time at University of Pittsburgh, as well as secondarily in peripheral nerve surgery at WashU. And so I've been a Methodist now for 6 years. I've shown this up with a QR code so that you can always look at the website, get information about the different procedures, or if there's ever any questions, of course, just send me a message through the website even, and I'm happy to answer that. So functional neurosurgery, as I mentioned, is really targeted surgical interventions, really focusing on specific disease states with new techniques in a multidisciplinary way. And we modify the functioning of the nervous system rather than operating on a brain tumor an abnormal brain or a blood vessel between the brain. We're operating and changing the function itself. And so functional neurosurgery is really equivalent to a restorative neurosurgery approach that we take in Parkinson's disease. And we'll talk about that through this as well, focusing on DBS. There's some key procedures. I mentioned this before. We do many things like deep brain stimulation surgery. Of course, I do epilepsy surgery, chronic pain neuromodulation, gamma knife focus ultrasound. We can talk about any of these subjects, as well as gene and cell therapy, which I talked about through our HAPS partnership with a research seminar. If you plug in to ChatGPT what I do, this is what shows up, like electronic interfaces, injecting gene therapy, doing neuromodulation and stimulation for Parkinson's disease. But in reality, what I do is I'm standing in the operating room. Sure, I have a robot helping me with surgery. The robot is not doing surgery. It aligns to trajectories so that we can hit the targets accurately. In DBS surgery, it's really important to be accurate. And I'll talk about why the robot is used at Houston Methodist and why we are really passionate about expanding its use, because ultimately we think that brings accuracy. So, but you know this already, Parkinson's disease, you're all here because you are invested in learning more about Parkinson's or have Parkinson's. And this is the second most common neurodegenerative disorder. There are 8.5 million people in the US and Western Europe that have this disorder. 2 to 3% of the population has Parkinson's disease that are greater than 65 years of age. What it does is it's a neurodegenerative disorder causing neuronal loss. It can cause neurocognitive changes, mood changes, as well as motor or non-motor symptoms. And in particular, the incidence is increasing. So over time, with each passing year, more and more patients at various age groups are diagnosed with Parkinson's. Men are increasing, women are increasing, younger patients are increasing. And as the patient population ages, the prevalence of Parkinson's increases. So this is rapidly becoming a public health epidemic that needs attention, funding, support, and therapies being pushed to patients to make their lives better. And it turns out that the vast majority of patients may not even see a neurologist. More than half of patients with Parkinson's disease do not even see a neurologist. That's because of access. While there are 15,000 neurologists in the United States, mostly those neurologists practice in metropolitan centers. So you can imagine patients that live in rural Texas or rural Louisiana may not be able to get access to a good neurologist to manage their Parkinson's disease. And out of all of these neurologists, only 660, again, plus or minus, are movement disorder trained. So you can see there's a bottleneck of access. That's why patients wait months and months to get to the therapy or the medicine that they need for this. And the point of this is we need to improve access to neurology, but ultimately surgical care, because that's where your bang for the buck is in terms of reducing the Parkinson's symptoms. So it turns out that over time, the effectiveness of medicines decreases. So in earlier Parkinson's disease, you have motor fluctuations that are less frequent. You have a large therapeutic window. And then as you go through time, as the Parkinson's progresses with many years, you have more time where you're either in the on state with dyskinesias or in the off state where you're having Parkinson's symptoms. And the therapeutic window really narrows. It turns out that 2 out of 3 patients experience motor fluctuations with Parkinson's disease, that 1 out of 3 have troubling dyskinesias. 50% of levodopa-treated patients develop these motor fluctuations. So you can see as each person develops the disease at different rates, the symptoms at different rates, but ultimately the funnel is that the on-off time becomes something where there's troublesome motor and non-motor symptoms. So it turns out this has been studied many times through the past several decades. DBS is not a new technique. It's been FDA approved for more than 20 years, right? It's been in clinical trials since the 1980s for Parkinson's disease. And many, essentially all trials have shown that deep brain stimulation is superior to medical management. Obviously, there are risk benefits. We can talk about those. But in terms of dealing with troublesome dyskinesias, DBS gives the biggest bang for the buck in reducing those dyskinesias. In terms of improving on time for patients and reducing off time, DBS is better. And if you could put head-to-head studies, which have not been done with DBS, infusion pumps, medicines, etc., DBS has always consistently been the best for managing patients' on-off symptoms. And there are nuances to this, of course, and so I would recommend talking to the neurologist or seeing a surgeon and having nuanced conversations about these issues. But DBS is the biggest bang for the buck in terms of reducing Parkinson's symptoms and reducing medicine doses. It can help things like bradykinesia or slowness, rigidity, resting tremor, reducing medicine doses, improving dyskinesias, but it may not help balance problems, gait problems, memory issues, or situational depression. And it's important to know that DBS response is really related to how the patient is, whether they're a candidate for anesthesia, whether they have good medical health, whether there's no dementia, and what their global picture of Parkinson's looks like. So it's really important to get a good vetting examination and seeing a good neurologist beforehand to make sure that you're a good candidate. And ultimately, I'm happy to see any patient and talk about their risk benefit and their ability to undergo a surgery. DBS is far better and safer today than it was even 20 years ago. We have good techniques, not only with the Lexel frame improving, but with robotics, as I mentioned, and MRI-guided procedures. And so this will highlight some of the reasons why we use robotics. So the goals of DBS surgery, we want to accurately place the lead at the target. It always works better if it's in the right spot. We can verify clinical efficacy and symptom control, but also we can evaluate if a patient's able to be awake. We can evaluate for off-target effects or side effects of stimulating surrounding structures to minimize those. The last thing a surgeon wants to do is to hurt you in the process of trying to help you. We reduce surgical risk with like bleeding or infection, of course. And then we share the operative findings with the neurologist. Ultimately, they're the ones programming you. And so what we learn in the operating room should quickly translate to them to make efficient programming sessions more effective. This is the pathway for patients when they're awake. Typically, what we do is we place a Lexel frame, the head holder frame, with the patient under sedation or while they're asleep. Of course, not to cause pain, so they're not in discomfort or things like this. We then get a registration CT scan. We register the robot. We start the surgery, again, with the patient asleep. And then we wake the patient up in a controlled way once the openings are made in the bone. We perform microelectrode recordings and stimulation testing, and also really make sure that the DBS leads are placed appropriately based on physiology, as well as this awake testing. When we're satisfied, we secure the leads, close, and get a final verification CT scan. In the old days, we used this Lexel frame, this middle picture, where there's an arc, an X, Y, Z component, where really you can dial in manually to hit a target within the brain. But in today's world with DBS, most patients, at least at Methodist, get robotic guidance. And there's a reason for this. In the ROSA robot or other robots that exist, of course, are stereotactic guides that line up to the appropriate trajectories in a highly accurate way and can be used for biopsies, keyhole procedures, endoscopic procedures, deep brain stimulation, etc. And it may reduce the variability in the operating room time, precision improvements, etc. Before I came to Houston, I was in Pittsburgh still. We published this paper with the learning curve of the first 20 patients using ROSA robot for deep brain stimulation placement. And I was really proud of this paper because this was the first paper showing this workflow. And there was an initial learning curve, 1.46 millimeter error down to sub-millimeter, 0.8 millimeter error. And to put it in comparison, the error of a Lexel frame is about 1.3, 1.4 millimeters. So we were doing better in terms of being more accurate with advanced usage of the ROSA robot. Since this paper came out in the past 6 years or so, 7 years almost, more than half of the academic centers in the country have converted to using this registration method. So it's kind of cool because things that I worked on, even as a resident and fellow, translated to make DBS surgery better for the entire country. And so I'm really excited to bring that again to Houston Methodist. And the reason why it makes it better is because, as I described, you take the frame and you dial in everything manually, there's a lot of random error. What I think is 86.5 is actually 86.8, right? I'm looking at the markings on the Lexel frame. That introduces random error. With a robot, you can remove that random error, and there may be a systematic error related to other things like air getting into the skull after the first side is created, et cetera. And so we looked at our numbers, our data, looking at essential tremor and Parkinson's patients. And in the first few patients, there was a discrepancy. There was a systematic error where the DBS lead on the second side was always shifted a little bit more medial and posterior. And by understanding the systematic error as a result of air getting into the skull, we were able to develop a correction factor. So now our DBS leads hit the target. And this is something where surgeons have to iteratively go through and look at outcomes and make their outcomes better for their patients. So only by doing hundreds of patients surgeries And now we have this data that really can improve DBS surgery to be accurate. We perform intraoperative physiology recordings, mapping the brain structures as we go down. And the reason we do this is, number one, because we want to get the data that we're in the right spot in the subthalamic nucleus as an example, but also we want to map to something called local field potentials. I'll introduce this concept later in the talk and why it's important for DBS programming. But suffice to say that local field potentials are a measure of brain activity that can be abnormal and can be related to abnormal states in Parkinson's disease and particular frequencies. And so there's a reason we detect this in the operating room so that we can make programming more efficient for patients. So we detect this, we get complex reports, we show that the lead is in the right spot, stimulating in the areas of relevant structure with directional contacts. Then ultimately, we give these reports to the neurologist so they can do more effective programming. On the bottom right is a brain sense picture with Medtronic. And you can see the beta band, which is this frequency of LFPs correlated with rigidity, stiffness, slowness, and Parkinson's, is markedly high initially, right? In this sense channel 0 to 3 contact. And so this is the frequency band that we're going to end up trying to reduce through brain sense related DBS with Medtronic. We then get advanced imaging and verify electrode placement. But patients may not want to be awake. They may want to be asleep. And if they're asleep, that's okay. We can still get good efficacy. But the workflow for this is that a patient essentially stays asleep the entire time until we get the final verification for accuracy. This has some pros and cons. If a patient is asleep, we may not be able to have those discussions to verify or reduce side effects. This being said, outcomes have been quite good despite the two methods. And then there's a third method, which is an MRI guided procedure, where the entire procedure is done in an MRI with real-time guidance. And I can showcase that in a moment, but Methodist is the only system that does this for adults really in the Houston community. The way that works is a patient's positioned in the MRI scanner, their head's rigidly fixated, it's in a single position, you're under general anesthesia. We attach this tower with different colored knobs to the patient's head. Those knobs allow us to vary the roll, pitch, X and Y coordinates. And that then allows us to pass an electrode to a particular trajectory on either side of the brain to place DBS leads or cannulas for gene therapy or laser ablation bolts for epilepsy or whatnot. And again, the way that it works is you dial in the coordinates to the ClearPoint tower. This shows the desired trajectory is yellow, and it's currently set to the red trajectory, which is not desired. And you do a series of roll, pitch, X, Y adjustments to align the desired trajectory to the actual trajectory. And so I'll just let it play through so you can see that. So they're making these roll adjustments to get it in the ballpark. And then once that's there, then they tighten the roll lock and do the X, Y to bring it to the actual desired trajectory. And so we do this procedure again for gene therapy, cell therapy, DBS, et cetera. And so ultimately, which procedure to choose? Well, there's some surgeon choice, of course, but there's also the patient choice. And awake surgery allows you to do functional testing to make sure that you're getting good efficacy, as well as make sure that there's no side effects or off-target stimulation that can happen with the deep brain stimulator to make the programming, I think, more effective. It's the gold standard. But ultimately, it turns out that the outcome difference between awake and asleep surgery is not well supported in the literature, that the two are essentially equivalent in the literature. And so patient preference is really heavily considered. If somebody really doesn't want to be awake, we can still take care of you and do surgery accurately with you asleep. Now let's talk about local field potentials. So brain activity can be measured at different levels. At the outside of the skin level with scalp electrodes, just under the skin, just under the bone, you can detect electrocorticography under the subdural space on top of the brain. Inside of the brain, you can get local field potentials, which is more of a population firing, or you can get individual spike firing of these action potential spikes. And LFPs can aid understanding like brain health because you're looking at populations of neurons and how they are affected in disease states. So let's look at an example here, which I really like this example. Since the World Cup is coming up and since soccer is here in Houston, let's look at this analogy. So on the left, you have a picture of the whole stadium. there's a microphone listening to a single person in the stand giving, singing, cheering, what have you. And so that's the microelectrode recording. That's a single spike unit firing. So it provides information about single neuronal characteristics and does not provide a broad picture of how the entire stadium is cheering or whatnot. The local field potentials look at the entire stadium, look at all of the people in the stadium, all of the neurons in the population of the related nucleus. And so you're recording from a much larger population, and therefore you have the presence of neural synchronous or desynchronous, aligned or unaligned rhythms that can happen that can be pathologic, like in Parkinson's disease. So LFPs are really important because they allow a picture of the global health of the surrounding cells to a DBS lead or the relevant nucleus in Parkinson's. And so, as an example, this beta band may be an off signal, like this is where you get akinetic, rigidity, slowness, etc. And there's a gamma band, which is more of a prokinetic symptom. And so we can understand this in terms of how this may affect Parkinson's symptoms, either slowness, stiffness, or dyskinesia, rigid, tremor, things like this. So it turns out that these LFPs can be used in clinical practice in Parkinson's disease. So the LFPs can be stable over time, stably recorded and measured. They correlate with clinical symptoms, again, as I mentioned, with beta band in particular. They can correlate with therapy being on, off, and the medication also being given on or off. And they can be used to inform clinical management. So if we see that the LFP still remain elevated despite DBS or medicine, well, then we can devise a strategy to decrease LFPs as a biofeedback mechanism, which I'll show you in a second. So the way that this works is we take the raw signal LFP, we perform some mathematical transformation, and get a broken down picture of the actual frequency. So the beta band here is 22.5 hertz, which is typical. And you can see that pretty clearly on the Medtronic software. You follow that beta band over time and see that it can increase or decrease with the disease states and stimulation changes of the DBS system. So as a patient takes their Parkinson's medicines, the LFP beta band goes down. And then a few hours later, after it wears off, it goes up again. And it oscillates over time. And so you can follow that as a real-time frequency measure. BrainSense technology is available in the Medtronic system. Medtronic has really invested heavily in this, and they're the only company to do this thus far with Parkinson's disease. And so you have this biofeedback mechanism that can help with determining the local field potentials in the particular contexts of interest, that can provide a window into the patient's condition and their disease state, and then ultimately offers the patient or the clinician the ability to adjust the stimulation settings to adjust with the disease state as well. So the Percept family is the newest stimulation battery with the non-rechargeable and rechargeable generator. There are multiple different DBS leads depending on target and the length and spacing that you want for the particular target. And they all incorporate the BrainSense option as well as the SenSight directional leads, which are the ones shown at the bottom of the picture. There are two batteries, as I mentioned. The first is the non-rechargeable. Most patients, at least in my practice, seem to be getting this because you sort of set it and forget it, right? It's designed to adapt. It has all of the BrainSense features in it. It's not a large battery. It's a very small non-rechargeable battery. And it lasts generally, I'd say 3 to 5 years, upwards maybe about 4 to 5 years in some patients. And it really gives the ability to get all of these features in a system where you don't have to charge it regularly. And some patients don't want to deal with that as they're going through many of the initial programming steps with deep brain stimulation. However, some patients need a rechargeable battery. So let's say the first battery doesn't last very long. Well, the second option is an option then. And that would be the rechargeable battery. So it's a really small, really thin battery, and it allows all of the same features, and it can be charged under normal conditions from 10% to 90% in less than an hour. And it's been tested to capacity at greater than 15 years to hold the charge. Imagine if your iPhone did that, right? We're replacing phones every couple of years because the batteries wear out. This battery is tested to 15 years. And so the good thing about this in some patients is that, yes, you have to charge, but it does give the ability to decrease your battery changes over the course of your life. The way that the BrainSense technology works with Medtronic is that these local field potentials, as we established, have information about the brain fluctuations experienced by a patient. With the DBS therapy with the DBS therapy off, there's that fluctuation of the on-off symptoms like we talked about, where there's rigidity, slowness in the off state, and dyskinesias or those abnormal movements in the extra on state. And so turning on DBS therapy really narrows that down, flattens the line, so there's more time in the on state and less in the off or dyskinetic state. But with the local field potentials, you get additional information. So what that is the DBS therapy can be on, you're getting that reduction in the symptoms, but ultimately you can follow the LFP bands at the same time with it. And so as this therapy goes on, you can see that there's more time in the on state, the beta band signal gets decreased. And so therefore you get fluctuating beta LFP that you can follow and can correlate with symptoms or medication use. So this is important because many neurologists like the data. They like to know how you're doing besides that 15 minutes, an hour that you're in the office. And so when a patient's not in the clinic, there's an electronic diary stored on the device. You can get objective monitoring of the LFP changes over time. As you take medicines, it can create a timestamp, or if you're sleeping, it can let a neurologist know what's happening while you're asleep. You can record not only beta band, but many bands that correlate with different symptoms. And it provides objective data ultimately that you can rely on that helps you outside of the clinic setting to really guide your Parkinson's therapy. So the way this works in clinical practice is, on the left here, you see this patient who's quite symptomatic, walking slow, rigid, akinetic. He has this beta band that's appreciable, and you can see it as marked there. With the stimulation ramping up, the bottom picture shows the ramp up of the stimulation and also the LFP band power. And so you can see as that stimulation ramps up, the beta band decreases ultimately with time, and that results in the patient's symptoms getting better. So he's walking more clearly, more fluidly, etc. So this is the power of how BrainSense can be incorporated into clinical practice and following a clinical biomarker like the LFP data. And it turns out Medtronic took it a step further. So not only is this the foundation for understanding how clinical symptoms may or may not correlate to brain activity, but in the old days, the implanted neurostimulator, the INS, did not give feedback. It provided information about the disease state, but it didn't adjust for fluctuations in real time. Now that we have that biomarker, imagine a system that can detect changes in the local field potentials and then adjust automatically the stimulation parameters to really optimize and decrease that therapeutic window, increase that therapeutic window even more. So stimulation is automatically adjusted in response to the patient's needs with the adaptive DBS option. And this was studied in clinical trial and recently FDA approved. So the way that this works is there are two different ways of measuring the LFP bands, on a single threshold or a dual threshold. Most patients, I think, these days are getting dual threshold stimulation where you set an upper and lower limit. And some are just getting a single one, right? And so the study initially looked at both of these options in terms of saying which one was better or worse, if they were feasible, et cetera. And this was a trial that was published. The ADAPT PD trial was the first study to look at chronic adaptive DBS in the subthalamic nucleus or globus pallidus, the FDA-approved targets for Parkinson's. They compared the single and dual threshold stimulation with adaptive DBS with the directional stimulation to look at the safety, effectiveness, whether it was an adaptable clinical workflow, whether patients liked it or not, right? And the clinicians liked it. And ultimately, the results were published. So it turns out that the study was designed so that patients got the Medtronic Percept PC, the non-rechargeable system. They were on regular standard DBS, chronic or non-adaptive DBS for 30 days. Then they went into adaptive DBS setup and then separated, randomized into two different groups. Those groups were dual threshold or single threshold, and then they switched over to get ultimately to collect data on enough patients to understand the differences and the feasibility, et cetera, of the system. And the patients were generally in 60s and their mid 60s with Parkinson's duration of 13 and a half years, with dyskinesias for many years and motor fluctuations. They were taking levodopa, similar to many of you on the call today. There was mostly male patients in the study, and there was a mostly STN, which is what we do predominantly for Parkinson's, at least in my practice. And the patients had the UPDRS scoring there as well, which is the standard rating scale for Parkinson's. And what they found is that for single threshold adaptive deep brain stimulation, again, just having the one biomarker, one LFP band threshold, they saw that you got at least half an hour or more a day of on time. But with dual threshold DBS, again, what most people are getting these days, they had 1.3 hours of additional on time. What does that mean, 1.3 hours of additional on time? Well, let's look at column 1 here, which is in the middle of the screen. That is a study looking at best medical therapy versus regular chronic DBS from more than almost 2 decades ago at this point. And DBS did, served a patient with 10.5 hours or 10.9 hours more than standard medical therapy, right? Column 2, column 3 show DBS therapy versus, again, chronic best medical therapy, and then looked at increasing adaptive DBS and then looking at dual threshold DBS mode in the column 4. The green column shows that you have that extra 1.3 hours of benefit. That's 1.3 hours extra a day. That's more time in the on state with less troublesome dyskinesias. Patients wake, that's 85% of an average person's waking hours. So you can imagine this is giving patients a better quality of life. That 1.3 hours, you can do a lot in that 1.3 hours. So it turns out patients obviously preferred this. 98% preferred this over the traditional DBS after using it for 30 days. It addressed symptom fluctuation, motor symptom improvement, and managed side effects. So patients were generally pretty receptive to this in the trial. So the summary is that patients reported this 1.3 hour gain in on time versus the stable chronic DBS as we would know traditionally. They were satisfied with therapy, that the therapy was safe and feasible, that most patients were able to get this set up in a pretty safe way, that it aligned with current labeling for DBS, that they can still get MRIs and all of these things, and that you can, so this is being followed, of course, long term, and we've had many patients in the Houston area activated with adaptive DBS settings. So I went through a tour de force in about half an hour, and the summary of this is that deep brain stimulation is a safe technology to address Parkinson's disease symptoms with a low side effect profile. It is not a therapy of last resort. It should be initiated earlier, I think, in the disease because there's more salvageable years. You're not having motor fluctuations, bad symptoms, costs related to medicine, side effects related to medicines. And so initiated earlier in the course, at least discussing it earlier in the course is really important. And it can be personalized in particular ways, whether asleep or awake to a patient's preferences. I think that local field potentials and the biomarkers related to Parkinson's disease can be recorded in the OR and are currently being used to facilitate DBS programming. This is the basis of adaptive deep brain stimulation. And ultimately, adaptive deep brain stimulation improves the on-time of patients beyond what standard DBS can do. So with that, I would say that Parkinson's disease really is moving to the next step, which is the future related to DBS neuromodulation. It's a great technology. It's a great application. I'm privileged to work in the med center. I know it's hard to get here sometimes, but trust me, it's worth it. And I'm always available for telemedicine or questions or emails or what have you. So my contact information is provided here on this QR code, or go to myname.com, and you can always send me a message. I'm happy to discuss with anybody about these options or others. So with that, I would just say thank you.
All right. Thank you, Dr. Faraji. Lots of questions
Okay.
that we have. And, just to put in a plug, if you don't like going into the medical center, you can always contact TAPS and we can provide transportation so that you don't have to navigate traffic, death
I
by
didn't know that,
plane, or
Kathleen. That's
parking.
great. That's
Yeah.
a great option. Can you
Yeah.
bring me to work actually tomorrow? I would love that if you could do that.
We'll talk after this.
Okay, sounds good.
All right. So we have a lot of questions, which is great. I'm thrilled people are putting their questions in. Let me just start with this. So just before you finished up, you said that this is a therapy that can be utilized early. How early?
Well, you want to see some effective medicines first. You want to trial medicines, but ultimately you shouldn't spin your wheel with medicines for 18 years, right? Like you should at least have a conversation about DBS. I think even 3, 4, 5 years in, whether you're a candidate or not. And this is especially important if you're elderly, right? As you're accumulating medical problems. You do not want to be the person that comes for surgery when you're 85 years old, has had blood thinners, on blood thinners, has had strokes, etc., because then it may be out of the realm of possibility to do DBS surgery, right? I'm not saying do this when you're 25 years old prophylactically, but what I'm saying is you should see that there's a good medicine response, that your symptoms are getting better. Have a conversation early with a neurologist or see a surgeon, and then we can wait a couple years. We don't have to do it next week, but at least you have that information, whether you're a good candidate or what it takes to do DBS surgery in your unique case.
Yeah, we would tell people it's always good to learn early so
I
that
think
you
so.
know making you have that information with which you can make a decision later, rather than waiting too long and then, maybe it's not the best option. All right, let's talk about some of the things. So some of the things that DBS can help with or not help with. We had some questions about has DBS ever been shown to mitigate balance or gait issues associated with Parkinson's?
The answer to that is there's been a lot of conflicting literature. Typically, the answer is it's not the best therapy. There's really not a great therapy for dealing with gait issues in Parkinson's disease. There are many trials looking at whether DBS can be optimized to make that better, whether again stem cell or gene therapy can do that, whether spinal stimulation can help with that. So a lot of clinical trials being explored to look at that particular aspect. But the balance circuitry is very complex. That involves coordination with cerebellar balance centers to the motor cortex, planning, and ultimately relies on you having a good intact spinal cord without degenerative disease and nerve function. And so you can imagine it's quite complex. So the answer is we don't promise gait issues, but certainly I've had patients benefit from it, personally, anecdotally.
Okay. And what about sleep? Does adaptive DBS improve sleep?
So many Parkinson's medicines have side effects. All right, I believe I mean, they're great medicines. It's changed Parkinson's completely over the past, 50 years or longer. But those medicines have side effects. One of them could be sleeplessness, agitation, hallucinations, insomnia, things like this that happen at night. If you're decreasing levodopa equivalents with DBS, then theoretically you're also improving sleep or reducing those side effects. So sleep is again many faceted. Whether you drink too much caffeine or not can cause you to not sleep, right? But intuitively, if all things equal, if you're reducing levodopa because of DBS, you could potentially improve sleep also and the quality of sleep. I don't know if that's been studied. I would have to double check on that, but that just makes sense to me.
So kind of secondhand benefit,
Yeah,
maybe
like a
not
secondhand benefit.
necessarily.
Yeah,
Yeah.
exactly. I think so.
Okay. Um, so and then can you just clarify, is brain sense the same as adaptive DBS?
Brain Sense is well, I'll let Medtronic answer if they want, but Brain Sense is a feature on the Medtronic platform that allows you to read LFPs, the local field potentials. And Medtronic took that ability a step further to do adaptive DBS, which uses those LFPs to then create adjustments automatically with the DBS system to correlate to symptoms. I don't know if you want to expand on that, Judd or Todd, but that's what I would say. So
No, you hit it on the head. So brain sense is essentially the name of the software that collects that data from the brain, and that also includes in that suite of software adaptive stimulation. So it's a broader term when you say brain sense.
Okay, thank you. Since there's no cure for Parkinson's, how long does DBS typically last before it doesn't help any longer? I think this is kind of falling into that idea that, that old school idea that we had that maybe medications, quit working as well, but it's not necessarily the medications, it's the disease that continues to progress. So how would you answer
Absolutely.
that?
The disease always is progressing in the background, right? Unfortunately, until we have that agent that really knocks it out of the park. But the point of DBS, I like casually say to patients on a simple terms, is that it kind of resets the clock. It takes many of the troubling symptoms and resets it and reduces them so that you reduce medicine doses. And yes, if you turned off your DBS, you would have symptoms return and the disease still can progress, but you're really jumping back up on the cliff rather than falling off of it with DBS.
So it's always working.
It's always working, exactly. As long as the battery works, it's always working.
Right, right. Okay, this person said that, and there have been a couple, this is kind of a theme of some of the questions that we've had. One, this person said, my wife's DBS implants were just over a year ago with Medtronic. Do we automatically have these features available?
The answer is, I think yes, but again, Todd answered, but I think the answer is yes. We can turn on those, and it depends on your neurologist, of course. And
Yeah, so this battery, our Percept family was started around 2020. And when we got this approved through the FDA, when you went to see your neurologist and they put that little wand over your device, it would upgrade it to unlock this feature. So you do have the software on your device now if you're in the Percept family, which started around 2020.
Okay. And this person said that they have been in support groups where they have heard people talking about the technology and that they haven't had the adaptive DBS turned on yet, and that they're being evaluated for that to see if they would be a good candidate. What does that mean?
I mean, it's up to the discretion of the neurologist. Many patients do quite well, don't get me wrong, with just regular DBS. Adaptive DBS is a really sweet icing on the cake for Parkinson's patients in particular, right? So you don't need adaptive DBS to be successful with Parkinson's therapy, but having it is a big difference.
And it could be turned off if you
Sure.
turned it
That's the
on and
good,
decided
and that's
that
the good
you
thing.
didn't.
Everything with DBS is adjustable and reversible. That's exactly right, Kathleen. Yeah.
Okay. Um, have let's see what this says. Have you replaced leads done prior to 2020 for the adaptive, and what does this entail?
So the answer is we have, but with new, and Todd, correct me, but with new generators, you don't necessarily have to take out the old leads. You can still do brain sense on the old leads as long as they're not super old. Is that right, Todd?
Yeah, all of our leads are compatible.
Yeah.
However, our Sensite leads, which are the newer leads, have more functionality to them. So we have a better success rate with them, but we can absolutely use it with the old leads as well. So you just need a new battery to upgrade to that technology.
Yeah, the reason I wanted to be careful about that is because exposing somebody to an additional brain surgery may not be necessary. It may just be a battery replacement that has to be done to the new, Percept battery system, as an example, which we can do very easily.
Okay, thank you. This one is a little more specific. So, it's up to you as to how you feel you can answer this, but the person said, post implantation, we noticed our doctor positioned my wife's configuration to her max limit. We discovered that we needed to start from the minimum and move up as needed. Does this align with what you generally see? I ask as the max setting resulted in spasms once the meds wore off.
So, like these programming questions, it's always a balance, first of all, when you do DBS programming, because you already have medicines in the system. Many patients that come to DBS, of course, are taking Parkinson's medicines. And so turning on a DBS system is great. You can ramp it up, you can test, but you should also consider decreasing your medicines as you do that. Because if you don't, then you are really creating your body to be super sensitive to those medicines. And you could have dyskinesias, which are those movements or spasms, as perhaps you're alluding to. So I think that's just a balance of decreasing medicines as you're increasing DBS settings. I think that's what it sounds like to me from what that question is.
Okay. The same viewer said on a separate note, her balance has greatly improved.
Yeah,
Head and shakes and tremors as well, and she is now comfortable engaging in social settings. So that's an
that's a great end of the story. That's perfect.
yes,
That's great.
Love it.
Yeah.
okay. Um, let's talk a little bit about what might rule a person out of being eligible for deep brain stimulation. Is there anything hard and fast that really counts somebody out?
Well, I mean, yeah, so a bad medical status, again, being on blood thinners you can't stop, or having major cardiac contraindications or what have you, sure, that you maybe can't undergo anesthesia. That's the biggest thing that I see in my practice. Sometimes as patients come in, they're really sick, right? And if they are, then we can figure out other ways or at least try safely to do it with DBS. Another thing is patients shouldn't have dementia. So you have to undergo oftentimes a neurocognitive assessment beforehand. And it's not like a pass fail. You're not going to fail. There's always an option for you, right? Unless you're floridly demented, which I don't think anybody on this call is. And so there's different targets for different reasons that are selected related to medicine reduction, symptom reduction, but also neurocognitive preservation, right? So that we're not affecting patients' memory and thinking as a result of DBS, which has in the past been associated with things, but we're not really seeing it in today's world with softer, gentler programming, et cetera.
Okay. What about focused ultrasound. So this viewer says that they've heard about focused ultrasound and wondering if you can have both if you don't get the outcome you want from focused ultrasound. They have not seen a lot of promising um, reports, I guess. And so they are just curious if you chose that route and then you didn't get what you wanted, if
Yeah,
this route was also still available or if that
yeah,
closed that door.
that's a great question. I mean, I did a focused ultrasound case on a patient who had a unilateral DBS lead just this week, right, to the opposite side. And you can do things in a very particular way for the right patient. So I think having that conversation, seeing the surgeon and determining the feasibility is really important. But in general, if you've had focused ultrasound, you definitely are a candidate for DBS afterwards. Because it may have been that either the lead was not in the right, I'm sorry, not the lead, the ultrasound target wasn't in the right spot, or the effect wore off over time, which we can see sometimes with ultrasound. And so it's well published, and I've certainly done it in my practice. Placing DBS leads to the appropriate spot afterwards to help really improve the patient's symptoms. And sometimes, as many patients may know on the call, something that looks like an essential tremor at first may be treated, but then over time becomes really a Parkinson disease type disorder. And that needs a totally different treatment option at that point. There's some patients that have these mixed tremors, in other words.
Okay, thank you. Um, Speaking of, hold on, I just lost, sorry, we got several questions and it
That's
adjusted
okay.
all of my, adjusted
I really love the
all the
questions. I
things.
mean, I'm trying
Okay,
my
yeah.
best to answer them, but yeah.
Okay, so this one, so it just reshuffled my list. So this one is related to placement. You talked a little bit about placement. And so what is the difference? How does one's doctor determine whether or not it's placement in the STN or the GPI?
Well, again, that's related to like what your pre-op rating scales would be, how you respond to levodopa medicines, whether your age is older than 80 or not. Like there's a soft cutoff, of course, and neurocognitive status. If you, I guess, I'll put it simply. I'm not sure that like that's completely accurate, but I'll just say simply that there's two different targets. One is the standard target, and one is the softer landing target, right? And the softer landing target is for patients that are older, maybe have a little bit of mild cognitive impairment, maybe don't need as much bang for their buck in terms of levodopa reduction. So there's a secondary target, which is the GPI target. Most patients with DBS for Parkinson's that are younger and in the standard sort of rigidity, stiffness, slowness, tremor condition would get the STN target, at least in my practice at Methodist.
Okay. All right. This individual said he had DBS in 2017 and recently visited his doctor and a Medtronic, I think it's supposed to be rep, um, activated the adaptive DBS. Um, Sorry, he wrote this in several parts, and it made a huge difference for the better. So he just wanted to report that success, that it really kind of set the turn the time back for him, and he had great results.
That's really great. I mean, hopefully that this explanation of the clinical trial and why this was all developed in the first place. I mean, what I showed you in half an hour took decades to develop. What brain sense technology was, sensing brain activity at the same time you're delivering stimulation, and then ultimately creating a system that learns and stimulates adjustments according to the patient's symptoms and LFPs. That whole process took decades. It was millions and millions of dollars invested by Medtronic into it, all for the sake of helping patients with Parkinson's and hopefully other conditions, frankly, but Parkinson's in particular for now.
Okay. Do other institutions use the robotic surgery approach, or is that something that's more unique to Houston Methodist?
No, as I said, like more than half of the academic centers in the country started using it. So whether you're in Pittsburgh or here in Houston or other cities in California or whatnot, the ROSA system or robotic systems are used really, really widely now for DBS placement. In the beginning, there's a lot of like question whether it was efficient to use a robot or not, whether it was increasing time in the OR, et cetera. Anybody that's come to my cases knows that this is not an inefficient process. We make sure the patients are comfortable, we do it efficiently and safely, of course. And so I think that the jury is decided at that point at this point.
So that would just be a question they would need to ask the surgeon
Yeah, I
if
mean,
they,
what
one way
ultimately
or the other.
whatever the surgeon's like preferred way of doing it is, like they should stick with that way, right? But the reason I do it is because I believe that there's increased accuracy that's been borne out in the literature.
Okay. Has DBS ever been shown to improve speech issues associated with Parkinson's?
Um, that is a complicated point, and the answer is I don't know, truthfully. Right. I mean, some of the slowness of speech that could happen with Parkinson's, if you improve the fluidity and the decrease bradykinesia, perhaps that could get better. But it depends on exactly what that speech issue is, I think.
Okay. Um, this person had DBS in 2017 and has recently had problems with itchy scalp, I'm assuming around, you know,
Okay.
the placements. Um, is there an itchiness side effect, and can you do anything to help control the itchiness?
I mean, usually when I hear about itchiness, it's like related to the immediate post-op period as the incisions are healing. Every incision that heals always is itchy, regardless of your head or body or leg or wherever. It's always itchy. But a decade later, I think it could be anything from dry scalp. It's been it's summertime now. I'm not sure, truthfully, what would cause that. If the skin is thinning or not, I don't know. So I think that the answer is maybe it could be related, but it depends on a lot of factors.
All right. Next question is, in addition to adjusting itself, did I understand that the technology also gathers data for your neurologist to use?
Sure, absolutely. Like the neurologist can look back at basically a diary that's collected on the device and see how your brain's activity responded to your medicines, as an example, or when you're sleeping, how your Parkinson's LFPs look like, right? So you can do not only adaptive DBS, but it's like having a Parkinson's diary that your neurologist can look over. And Todd and Judd go to these neurologists' office and visit with them all the time. I think many are using this in their practice for Parkinson's patients.
All right. And you talked about turning it off, but is it possible to have the DBS removed from the brain? Has that ever happened? And if so, why would that happen?
The answer is yes, it's reversible and that you would need another surgery to take it out. Many patients don't want to take it out because it makes such a big quality of life improvement, right? So the reasons to take it out will be things like skin erosion or an infection or what have you. And it would come out just to maintain safety at that point. And in a couple patients, I mean, no surgeon's perfect. I've certainly had infections of, it's a low, less than 1% number, right? But the short answer is um, like a system coming out for infection doesn't preclude it going back in later. And most patients, even with a minor infection or skin irritation, fight to keep their system in. And the reason why is because it's made such an improvement in the quality of life. So there's a lot of literature that you can salvage DBS systems even with an infection, with IV therapy, antibiotic therapy, whatnot. And so we try to get everybody on board for these kinds of things here at Methodist.
Yeah. So gene and cell therapy are kind of these emerging, technologies that we're seeing. And I know that in the trial phase of things, this is not, people are not being included if they've had DBS. Do you see a future where people who've had DBS can still participate in I'm gonna like legitimate cell and gene therapy, like into the brain,
Sure.
gene and cell therapy, so that this is not something that they feel like they might need to wait on?
No, that I mean, so all of these gene and cell therapies that are currently being tested are in the phase 2 studies, with the exception of Blue Rock, which is a phase 3 study, which means that it is still several years away from potential FDA approval, right? And that's regardless of gene and cell therapy. So that's 5 years down the road potentially, right? And so if you're 75 or 80 years old, chances are you won't be a candidate for that if you're 85, 90 years old, right? So you should do something today. That's the first thing I would say. Do something today to preserve your quality of life now. In the future, I would say that you will have many patients that have mixed treatments, right? Patients that have gotten gene therapy, patients that have gotten DBS, because they probably are synergistic in some patients, depending on what status they are with the disease. Right now, the reason DBS is an exclusion factor for gene and cell therapy trials to the brain is just because you don't want multiple variables at the same time. It's simply just rigorous science. It's not that they don't work together. We haven't tested that, of course, but it's they just want one variable being tested, which is the efficacy of the gene therapy agent, the efficacy of the cell therapy. They don't want DBS as a confounder. But DBS alone is excellent. That's the point of the talk.
Right. And what about, so I'm going to kind of combine a couple questions here for you.
Okay.
One is what new DBS features are in the pipeline that people might expect to hear about over the next few years, which kind of leads into another area of concern that people expressed through some questions related to, I don't want to, what if the next best technology is still to come? And so I don't want to miss out on that. What thoughts do you have on that?
That's what you're describing is called buyer's remorse, right? And so you buy a new car and then the next year the new version comes out and you're like, oh man, I should have just waited a year, right? And the reason to think about this is, well, let's take a step back. It took Medtronic more than a decade or plus to develop these technologies. The chance of you getting some drastic change in the next 2 or 3 years, other than additional features, right? That would be software updates, frankly. I think that it makes sense to do it now because they're not going to come out with a new generation of battery or DBS lead or whatever, probably for another decade. And that's kind of holding with all the companies that we're saying is it takes time to develop the hardware and the software is easier to implement. So the surgery relies on hardware and the software can be updated later potentially. I
So
don't
a
know if
lot
that
of what,
answers the question, but
yeah, so a lot of what we've heard, people who've
yeah,
even 10 years ago had DBS with the Medtronic system and have recently been able to upgrade to the new technology.
that's right. As Todd mentioned, like even if you have the DBS leads from 10 years ago, all it takes maybe is updating a battery on a simple procedure to get many of these technology features, right? And the DBS leads themselves really have been around for 5 years, right? So that they're not going to come up with new leads again after just 5 years. I mean, imagine like a car, you would spend 10 years on a production cycle generally with some minor updates.
Right. Okay. And I think this might be our last question, which is kind of an easy one, but does Medicare and Medicaid and other insurance cover DBS?
Yeah, I mean, the answer is yes. Insurance covers this. This has been around for a long time. The technology today is way better than it was, 20 years ago. But I think having that conversation with the surgeons, come see me, guys. I'm happy to see anybody on the call. And we can go through the individual plans and make sure that things are authorized before the procedure, of course.
All right. Let me just double check all the devices that I have here sending me questions. Looks like we maybe have gotten through them. Todd, Judd, did you have anything that you wanted to add?
No, I just want to say happy birthday to the doctor. I see the balloons in the background there. So I know it was this past week. And great job, Dr. Faraji. And thank you so much, Kathleen, for having us. That was wonderful.
All right.
Thank
Well,
you.
thank you guys. Thanks, of course, to Dr. Faraji for his time, and thank you to Medtronic for their ongoing partnership. We are really grateful for that. And of course, as always, thanks to all of you for joining us this evening and sending us lots of great questions. And we look forward to seeing you soon. We will give you back the rest of your evening. But oh, this program was recorded. Medtronic does allow us to record the program, so it is recorded and it will be posted on the HAPS YouTube channel at some point, maybe not in the next 24 hours, but it will be there. So if you want to watch it over and over and over again, that is always an option that you will have. So thank you all for joining us, and thank you for the great presentation, and we'll see you soon. Good evening.
Bye, everyone. Have a good night.
Bye.